talk about breast cancer in general, but the estrogen receptor positive breast cancers, when they metastasize, are a bit more likely to go to the bone than the estrogen receptor negative breast cancer. So breast cancer incidence has increased over the last decades, and patients with breast cancer, they do live longer, and we are able to prolong the disease-free survival period. So we will see more and more patients that we have to manage with metastatic disease, and it's as such that this metastatic disease might come back in up to 30% of the patients with early breast cancer. And if it's metastasized, about 70 to 80% is in the bone. Very few patients in Belgium are de novo metastatic. And also there, if that's the case, then it's more likely in the bone than in the liver or in the lung. But indeed, sometimes it's on different organs. So what we try to learn today is the current status, like epidemiology, the disease burden, early identification and assessment, prevention, treatment strategies, and I hope we will have a nice discussion. So bone is a frequent site for breast cancer metastasis. Tumor cells colonize the bone microenvironment. It can be in a dormant state, it can be in a symptomatic status. There is bone destruction, it can be mixed, it can be osteolytic, it can be osteoblastic. So the tumor microenvironment, the primary tumor, contains cells like hematopoietic stem cells surrounding stromal cells, extracellular matrix that interact dynamically, influencing the cancer cells for their invasion and metastatic potential. Otherwise, the bone is a microenvironment that is very fertile, and they call it the soil and seed. So the bone is the soil promoting cancer growth. So the seed and soil hypothesis, already mentioned by Sir Paget ages ago, describes how cancer cells exploit the bone that's made compatible for the cell to attack the bone, and the bone marrow microenvironment contains mesenchymal stromal cells, providing signals that can support this growth and then lead to considerable morbidity, like skeletal-related events, pain, fractures, impairment of quality of life. And there is a lot of knowledge about the pathophysiology, which are the growth factors, which are the cytokines that are produced in this microenvironment to make bone metastatic disease potential. There is a major role of osteoclastic function being driven by the rank and the rank-L interaction on the osteoblast, on the osteoclast precursors. And that's the pathophysiology where we can interfere with bone metastatic disease prevention, but also treatment. So metastatic disease from the breast is very often osteolytic, but can be osteoblastic or can be mixed. So what as clinicians can we do? This is a 25-year-old paper in Cancer, when we didn't have these treatment opportunities and where the disease appeared earlier. And 25 years ago, prior to bone targeting treatments, 1 year after a patient presented with bone metastatic disease, the median time to the first skeletal-related event was about 7 months, and patients now have a doubling median OS. So we are confronted with patients more likely to have bone metastatic disease. So we need to control the disease. Otherwise, we will have fractures. The need for radiotherapy is very high. Hypercalcemia that we very unlikely see today in the clinic. We have less orthopedic surgery. We have less, but it still happens, spinal cord compression. So this is really a very important topic when we talk about breast cancer management, not only for treating bone mets, also for prevention of bone mets. If it's already in the metastatic disease, current bone agents that target these osteolytic osteoclasts, just putting them at rest, They inhibit tumor-associated osteolysis, pain, and they prevent hypercalcemia, pathological fractures, and spinal cord compression, together with radiotherapy, orthopedic surgery, palliative care. And there we have two main drugs. There are several other treatments, but we will focus on the bisphosphonates and on the denosumab, which is a monoclonal antibody against the rank, and that leads to inhibition of the osteoclast. So we have two drugs that have been compared, one with the other, and it seems from these randomized controlled trials that denosumab is a little bit more favorable than zoledronic acid, 17% less time to the first skeletal event, 18 for the subsequent skeletal related event. And so it delays these skeletal events more and better than the zoledronic acid does. But the overall survival, comparing one with the other, is not better. But we seem to be more able to control this bone metastatic disease based on all these skeletal related events, hypercalcemia, fractures, and spinal cord compression, including the time to radiotherapy, the time to orthopedic surgery. There are ESMO guidelines that have lastly been updated in Annals of Oncology 2020, and that's where you can see these guidelines. Regarding side effects, there is a difference. You know that zoledronic acid can only be prescribed if the renal, the kidney function is normal. There are other side effects, and we always wonder if there is less osteonecrosis of the jaw, which is the most important side effect, because this on its own leads to palliative care and patients can die of it. So this is what we have to avoid. We have risk factors. We have two potential good drugs with a similar efficacy, but both of these drugs can induce ONG. So hypocalcemia, skin infections, hypersensitivity, renal toxicity, it can be induced by bisphosphonates. Acute face reactions by giving the infusion versus the subcutaneous injection. So these drugs are different regarding to side effects. But, you know, we have them for a long time. We know these drugs. We can see the patients with particular risk factors. And then we have to choose between one or the other drug based on the individual risk to develop such ONG risk factors. So what about patients with early breast cancer? Do we have tests to screen for bone lesions? We don't screen for bone lesions in patients with early breast cancer. We do assess the bone if patients have symptoms. In my country, we still do a lot of biomarker assessment in patients who have been treated for early breast cancer. We do measure CA15.3 on a quite regular basis. Of course, 5 years out of the disease, we do it only yearly by the general practitioner. And if there is a signal that it might be a patient who has progressed, we in Leuven prefer doing PET-CT rather than bone scintigraphy. We also have developed a very sensitive test, which is called the whole body MRI, where if patients have lobular breast cancer, we do believe that this is the best way of detecting metastatic lesions in lobular breast cancer. So, but we now have very good tests to detect very early on these patients. We don't look for bone relapses that are biomarker driven, like tumor cells or circulating tumor DNA. But we do participate in such studies where if the patient might develop not anatomical progression, but molecular progression, interfering a bit earlier to prevent metastatic events, these are ongoing trials also in our institution. Also here, we have drugs available, and these are actually the same drugs that have been tested in clinical practice in patients with high risk early breast cancer, also in patients with triple negative breast cancer.